first roundtable with Agarwal, who is head of the Center for Innovation for Digital Health. Professor, please come. She's associate professor to the Health Medical School, Johns Hopkins in Baltimore. Please give her a big round of applause because she came from the United States to take part of the meeting of the e-health observatory, and then on the other side of the planet from Europe, Aparna Hegde, who is joining us too. She's urogynecologist at the Hospital of Bombay, and she's still working there. She's working as a gynecologist. And then you have founded the NGO ARMMAN in India, who uses many digital tools to come and support pregnant women and newborn babies. We're going to come into detail into that in a few minutes. In duplex from Geneva, from the World Health Organization, we have Tigest Tamrat. I think she can hear us. She's a scientific expert, and she's going to tell us about a technical brief on artificial intelligence for opportunities and links for health. That shows really how relevant topics we are talking about are important, how important they are, because the World Health Organization is working actively on that. And then Caroline Perrin, who speaks, she's a German speaker, but her French is remarkable. Caroline, you're the executive director of Geneva Digital Hub. What is this structure in Geneva? Can you tell us more about it, please? It was co-founded with the agency, but the work is supported on the 20 years of implementation within different contexts of health. Thank you. You can tell us how you work to try to find proof of efficacy and non-efficacy for health in women. Aparna, I'm going to speak to you first of all. With the ONG you have founded, you work in India with mothers and their young children, and 2 children are really dying. 2 children aged of less than 5 years are dying every minute in India. Pregnant women can be not have the right follow-up in terms of health. Sometimes it's just a lack that hasn't been detected in a pregnant lady, so that the pregnancy doesn't go well, and you have social and medical workers who go at the women's places. I mean, it's very easy. We have images here, and it's good to see what it looks like in real life. Those social and medical workers, they have digital tools with them. They have also a telephone platform, and you have WhatsApp loops or information for women. So I won't say it's wonderful, but many other NGOs are proposing this kind of tools in their countries. But your difference is that your tools were designed for women. What does it mean concretely that they were designed specially for women, digital tools for women?
Yeah, the way we work is that we have a very grounds-up approach.
En fait, c'était conçu au départ avec cette
on the constraints of the women. So we had, so on the one hand, we have a voice calling service that handholds women through pregnancy till the child is 1 year of age. And the other hand, we train health workers through the health system. And we're through the country. We're at least 50 million women. Now, the thing is that earlier we would kind of work around the constraints that women faced on the ground. But what we realized was that it is not just enough to give information. It's so important to also understand the social and cultural barriers that prevent the women from exercising the behavioral change that we are espousing. And so when we went in the field, what we did was that we recognized that we have to actually now get the male into the system. Our content has now become gender transformative because the woman is not a decision-making entity in the family. it's the husbands and the mothers-in-law who exercise the control. The women, we inform them, but they're not able to kind of act on it, because at the time of decision making, the husbands decide what will get done and not done, right? So now what has happened is that it's actually the women leaders in our team that understood that we have to make a gender transformative format that now the family, the husband and wife together are the ones who we address in our content. They are the ones who, work together to make the decisions for themselves and their children, and they bring their other family members into the conversation. That's how we've transformed our content over time. So the men don't get involved only when there is, a crisis. They are engaged from day one. They are involved in the continuum of care, and also that they ensure that they engage with the wives in shared decision making. That the husband and wife together, decide for themselves and involve others when required. So this came in only because of the fact that we had, a team that involved women who understood the constraints in the field, because they were facing the same constraints. The field force who were engaged in the content creation process came up with this understanding from the field, and that led to this change, which is gender transformative. And this now been adopted by the government of India now. Yeah.
On entend bien dans vos propos justement l'importance de bien connaître le...
To know the context. The social context, what we have to do before we imagine the contest, whether it is the answer, whether it is a technical or not. You're saying that to understand well what's happening in the field, in certain communities, it's very important to have women who are talking to other women, because in some communities, women will not answer to social workers who are men. They're not going to give all the information. Can you confirm this?
It's beyond just that the women would not. Yes, it's beyond just that the women would not talk to men. It's about the fact that inequity plays a huge role in access to healthcare, right? So when we started off with health-based solutions, mobile health-based solutions, it was an equality-based lens. You have one program that goes to everybody. But what we recognized was that there are subsections underprivileged in India, being underprivileged in India. Like if you're a scheduled caste, scheduled tribe woman, if you're a Muslim woman, if you're an adolescent mother, you're a migrant mother, your access to healthcare is severely limited. And if technology does not design for this inequity, you're actually going to worsen the inequity, right? So, we have solutions where we, train health workers, right, through the health system, but they would not even approach scheduled caste, scheduled tribe women because of the hierarchical nature of caregiving. Migrant mothers are not tracked from source to destinations, So, and Muslim women, there are a lot of, difficulties in reaching out to them because they don't have trust in the health system. So what we are doing is to actually build systems, lateral approaches to these subgroups. So why not get every village has a self-help women's group. Why don't we use those groups to reach out to scheduled caste, scheduled tribe women, because they are from the same community and they understand the constraints. Same thing with Muslim women, right? We're getting in culturally nuanced content that speaks to them, involves community leaders and peer groups within the Muslim community. Same thing with adolescent girls, right? So it's very important to have adolescent health champions, who, communicate with the adolescent mothers to ensure that they get they listen to the information and content. So we are adopting lateral approaches to these subgroups. Yeah.
Vous citez à plusieurs reprises.
You're quoting two words that are really key, everyone know, which is information and content. You're talking a lot about that. Of course, you're saying information is empowerment. Of course, that gives empowerment to women if they get the right information. If we talk about content, so that we understand really concretely, what does it mean to you, a content that will be designed by women, for women, to allow them for the information to be conveyed? Is it only written by women? Only with a gender biased, woman biased?
We have men. In fact, we've got the male voice in. In fact, we're evaluating how men, respond to the content, and we're ensuring that their involvement is assessed along with it. And the first part of your question about information is empowerment. This is something that I really learned along the way, right? As a typical doctor, when I designed ARMMAN programs, as a doctor, you give information, you expect them to remember it, act on it, exercise behavioral change, we use the technical terms, and then there'll be improved health outcomes. And what I realized in the field is that, the women have it within themselves. They're very smart. These are all women who understand, have a sense of justice. And what we actually able to do is that when you give them the right information at the right time, they're able to, it ignites that sense of, knowledge, like the justice within themselves, and they go beyond what you expect. I'll give a small example, right? In the slums of Mumbai, there was this Muslim girl who was the wife of an Azan preacher, right? And she got pregnant, and during that pregnancy, she didn't get our service, the voice calling service that handhelds women. And then she got pregnant again within the first 2 months of delivering the first child. And she knew that there's something wrong, that you have to have spacing. Internally, she knew that it was not right for her body. And when she spoke to her husband and in-laws, they didn't agree, But then Mitra, our program, which supported the woman, came to her. It spoke of spacing. It spoke of family planning. And it really ignited inside her this sense that, yes, I was right. So she convinced her Azan preacher husband to adopt family planning. Right? And same thing with, examples of women who've given up wearing a veil, they've sent their daughters to English medium school. So this information goes beyond what we are actually talking about. It's intergenerational change. Yeah.
Smisha, je vois que vous aviez envie de réagir à ce que nous raconte Aparna, qui vient du terrain. C'est vrai qu'on a souvent soutenu...
Do you want to react to what Aparna said? We have supported many technical solutions, applications. First of all, it was a technical bias, but Aparna tells us that it is a sociological aspect that is very important. The application, the way it is built, is it going to reach the public it is supposed to be reaching? It's part of the themes that you're studying at university.
And yeah, absolutely agree with Aparna and the work that... with Aparna and her perspectives. So first of all, I think increasingly women's access to technology...
On va peut-être just change the microphone. I suppose that there are some interferences. If you can take Aparna's microphone, please.
Thank you. That women's access to technology over time is increasing. It's still not equitable. So on average, women are about 15% less likely to have access to mobile phones and internet connectivity than men globally. But it is improving over time, and the gender gap is decreasing. But access to technology in and of itself does not address the social and the digital determinants of healthcare, which is what Aparna is speaking to. There are some fundamental structural barriers in access to services that are deep-rooted in the culture of every community, of every country. And the programs that we undertake, digital or not, they must actively address those. So in the case of ARMMAN, ensuring that the images that are used represent men and women, because in India, in the context of India, often the decision-making capacity is within household elders, within the men, whereas the pregnancy is largely experienced by women. And so how do we bring them into the experience of pregnancy? How do we bring the men into the experience of pregnancy, as Aparna said? The use of imagery, the use of voice, whose voice are you using? The design of the digital intervention must address that, and that only speaks to the knowledge. Then there is access, right? Even if you are able to convey the right knowledge, people may not actually get to services because it requires transportation, requires financial independence. And how do we address that barrier? And then even when women do get to services, or even then when people do get to health services, there are other barriers to consider. So just noting that it's not just access to technology. We often limit ourselves there, but a gender transformative approach, as Aparna is alluding to, really entails addressing the ecosystem of which technology is a small part.
Smisha, une autre question pour prolonger ce que...
Another question. another question to understand what you're saying and to go beyond and to get away with prejudices. We thought that if we had applications on mobile phones, we would get directly to the end user, in your case, woman or young woman, and that we could talk about everything and address all messages and all news to these final end users and all medical results, as imagining they will all receive the information on their mobile phone and that it will be confidential. But we can see that certain messages are complicated to convey, are complicated. I'm talking about IST, of abortion, of HIV, sorry, and different news for the woman who's pregnant, and she doesn't want this information to be propagated around her. She wants it to keep it for herself.
The issues of access and privacy and security must be considered in designing digital interventions. There is, in fact, there is a lot of health information that should be private. But if mobile phones are owned or if they are shared by different members of the household, privacy is, of course, questionable in that case, especially when health information is sensitive. So there is some evidence that in cases where sensitive information is shared through mobile phones, there is increased likelihood of domestic violence. And so, and that might have to do with the nature of the information. And so there is a need to be cautious and to, I think there is a reason to pause and say, is mobile the right interface, right? Because in some cases, depending on the context or depending on the type of information, sending information as text messages or as voice messages may not be appropriate.
Aparna, vous développez très fort.
Aparna, you're developing a digital strategy. You've been doing that for many years. You have call centers, of course, where women can call and ask for help and ask questions. But you've been supporting also, and we have supported Association in Africa with call centers to answer often young women about, they had questions about sexuality and reproduction. In the northern countries, of course, with applications and mobile phones, we're going to really have access to many, many people in much quicker way, and then you don't need call centers anymore. How do you think you could balance your strategy between the voice, the call center, and the digital? What is the percentage, you would say, of the one of the and the other? Yes, what the question is, call centers might disappear because now you have applications directly sent and text messages sent directly on mobile phones. So what do you think?
We were a voice-based service. In India, SMS would not work because women can't read an SMS, open SMS. And, we started ARMMAN, but it was always voice-based, where we sent automated voice calls, hand-holding women and health workers. And we had a call center for additional support, for two-way communication. But now, because smartphone usage in the country has really spread, I mean, in tribal Jharkhand, I would like you to come and see how 70% of households have access to a smartphone. And now we're using multimedia approaches and two-way communication. So it's a video format, because our preliminary research showed video works the best. People really like to imbibe information where, they can actually watch for long. I mean, and what we have created now is a drama format around one family, which is followed over time through pregnancy and infancy. And so the families can learn by introjection. You're suggesting subtle behavioral changes, which is adopted by the family. And the way it is actually going to be is that the video goes across, and then there'll be a little quiz. And you'll be surprised how women in Jharkhand are responding to the quizzes and answering questions. So why the quizzes are important, because it allows two-way communication. They can give feedback. We can understand how much they've understood. And are they even exercising those behaviors? Because, say, for example, iron supplementation, we can follow them over time and then ask them, are they really taking those iron tablets? And based on the answer, we can send an affirmative moving poster, or we can talk about, if you don't exercise these behaviors, what can go wrong? So it's an interactive thing. And also, we're integrating AI So I'm very happy to say in Uttar Pradesh, so we have with women and with health workers, right? So we train health workers at every level of the health system. So the protocols have been, we've created a Gen AI-based, help desk, which has been taught those protocols. And so when the ANMs, the nurses ask questions, we have a stratified system where the Gen AI can answer because it knows the universe of the content. And then if there is anything, then the live person can get in when there are more complex things that can't be answered by the Gen AI. So we're going on to the stratified approach, which is making use of all the digital tools. And very happy to tell you that it actually works in the most rural parts of the country.
Smisha et Aparna, quand je vous écoute tous les...
When I hear you, Aparna and Misha, I realize all the possibilities one has for communicating and to reach people who are really huge thanks to this digital tool. And artificial intelligence multiplies the spread and the risk. Tamrat, who is with us live from Geneva, Tigest Tamrat, thank you very much for being with us, Tigest. The World Health Organization just spoke about, talking about those topics for AI and the effect for reproductive health, and you're doing the synthesis of 12,000 studies to compare, see how relevant the tools are, the risks they convey. Can you please give us a few examples of tools you're analyzing to see how diverse those digital tools are? Can you please tell us?
Me here, and it's been an honor to be alongside other panelists. So AI, as I think all of us know, has been a big buzzword over the past few years, and it has huge implications in sexual and reproductive health and rights because partly, as was mentioned, it's a great way for people to access information. There's a lot of stigmatized issues or issues that people may not talk about publicly or easily access services on, such as family planning, STIs, even pregnancy care and other issues. So, we've been seeing a rise in chatbots, not necessarily AI specific, but more recently because of Gen AI, as was mentioned by one of the panelists, we've been seeing a huge increase in the development of chatbots so that individuals, particularly young adolescents, people that are seeking information can, have some perceived an anonymous way of being able to access information. There is still potential around misinformation or not having complete information within these chatbots, but I think the technology is really advancing. And as was mentioned, digital devices are now in more people's hands than ever, and it's actually a really great way to be able to provide information, access to services, if it's done correctly and appropriately and with all the contextual considerations. Another big area that we're also seeing is in being able to analyze ultrasound images. So this has been done, I think, a lot with telemedicine, being able to share images back to people that may have more skilled professions and being able to analyze ultrasound readings in maternal health. But I think now there's increasing experimentation. We cannot definitively say what, the trend that these things are going in. We still need to do our research around this, but we do see huge trends in trying to address a lot of maternal health complications using either images generated from ultrasounds and having AI systems and tools be able to analyze it at a much faster rate, or to be able to access, to do it with similar clinical precision. We're also seeing,
Yes.
And then the last part I'll just mention is we're seeing a lot of use of personal health record information to be able to understand potential risk factors, to be able to potentially target interventions to those that may have, particular needs or risks for complications. So this is what we're seeing. We still have to wait to actually see whether there's impact coming out of this. Thank you.
Tigest, je voudrais vous poser, si vous me le...
Tiger, I want to ask you two questions. You spoke about chatbots, and they are very present in the study, in the technical brief you are sharing with us from the World Health Organization. and then it is a wonderful tool, the chat box, to answer massively to mass questions, but be cautious because we have risk with the answers we send to young people. I'm a bit naive, but I thought, who is going to give fake answers and to say to a chat box to give fake answers for young population? Who would think about that? Can you please tell me more?
Thank you. Yeah, so there's two ways. I mean, there's several ways this could happen. One is what we call misinformation, which is that maybe the chatbot could have hallucinations, which is, it thinks it's giving you the right information, but it may not provide the right information just unintentionally. So there's that aspect of misinformation where it's not, actively lying, but it may think it has the resources. And if it's particularly with generative AI, there are these things where it thinks it has retrieved the right information to respond, but it's not really correct. And you really have to make sure that you can decipher what is true, what is correct and not. And so there is that risk for people that don't know enough. This happens to me even with ChatGPT. You can get something that doesn't actually correspond to what you were looking for. And that's what we kind of call hallucination as well as misinformation. On the other hand, there's also something that we call disinformation, and that is where there's intentional. So it's not just an error or a bias in how the information is coming out, but the disinformation is where it's intentional. So this could be because of areas like sexual and reproductive health, where there's also politics around abortion and other sensitive areas. There could be potentially an intention to want to dissuade people to say, oh, this population shouldn't be using these types of methods, when, and just intentionally putting that out there because of other beliefs that are there. And, as was explained earlier, the social and cultural dynamics and ideologies that may be there. So we have to distinguish between the misinformation and disinformation, one being intentional and one being just unintentional. Maybe the system hasn't been advanced enough. But all this to say that in sexual and reproductive health, I mean, there is a lot of different thoughts. Should adolescents be using certain contraceptive methods? No, yes. And so there could be a way that the system is designed where it's kind of intentionally misleading the outputs that could come out of it.
Ouais, passionnant. Ouais, passionnant ce que vous nous dites.
It is fascinating what you're saying to us, but it is frightening to think that chatbox answers massively to thousands of young people and 100,000 and millions of young people. We don't know what the intentions are, ideas with a contraceptive method. They give disinformation and fake news, and they say that if certain contraceptive methods will make men sterile, for example. So what about safety of data that are collected from women? You're reminding states, NGOs, big actors and stakeholders to have the right intention. Not just the South countries, but also North countries. Data can be sold, and we have to be extremely careful because it could be really disastrous for women.
It's we shouldn't throw, as they say in English, the baby out with the bathwater. There's still a lot of great advantages to being able to potentially access information in this way. And if it's as well accompanied by other interventions that can really ensure that people are getting the services and it is being impactful. But there is, particularly I think in the high income countries, maybe there is this risk of wanting to use the data to be able to sell it, to be able to commodify and, maybe use it for other marketing purposes. It could be used to market pregnancy tests or other things like that. Or it could be shared with others and people not having the awareness of where their information is going. I think, AI is largely powered by data. And so we need to really think about how do we also ensure that there's protection of that data. But I think, these conversations are happening, and it's good to see that there is more thought happening in this space than probably even a few years back with legislation.
Et ceci, voilà, bien sûr, ce que vous rappelez dans le Nord comme dans le Sud, hein, qu'en France, une grande société aujourd'hui.
And that is valid for North and South. We have recently 800,000 euros penalty. A company had this penalty because it sold data without making them anonymous. So there's a real risk. Aparna, you wanted to talk quickly. Misha.
Thank you, Lionel. I actually just wanted to clarify a comment that you made. I think there is a difference between fake news, health programs, and health-focused conversational agents or chatbots that Tigest was mentioning. They do not spread fake news. Not typically. It would be an anomaly. So I think we want to be careful of creating information, of seeing this as threatening. Most health programs have some level of regulation where hallucinations are very much actively being thought about, and there is very much consideration for what the chatbot is responding with. In fact, most health-related chatbots are not AI-based. They are, in fact, they understand the input based on the use of AI, because what it has the potential to do is change the power dynamics, right? Aparna started with saying that as a doctor, I'm told what to tell the patient, right? And the doctor decides what the patient learns. A chatbot helps reverse that power dynamic, where the patient can ask freely in the privacy of their space what they would like to know, right? What they would like to know. They can ask in their normal language. The chatbot can understand that because of AI. In most cases, the responses are not AI-based. They are vetted, like in the case of ARMMAN, right? They come from a library of responses, and so they are not just telling you you'll go sterile or some, such information like that. They are vetted, and they are appropriate responses. So just want to be careful about how we are presenting this.
Yeah, effectivement, il est d'autant plus important de bien classifier.
And it is very important to classify things very well, to have the right classification. Aparna, very quickly.
For example, in our GenAI chatbot support, the universe of the content is very clearly defined by us. We created the protocols, and the chatbot takes the content only from that universe. And it's verified information completely, so it's not misinformation, and the hallucination is not there because of the fact that the universe is defined. And then obviously, it does have a library of answers. It also can create its new answer, but then it's verified by a live person sitting behind, right? So there are all these checks and balances in place. Yeah.
On voit derrière toutes les précisions. Hein.
One can see behind everything you're saying, behind what the World Health Organization technical brief that is coming out to really classify things and to prove the efficacy of the digital solutions.
D'évaluation, Caroline.
So in terms of Caroline Perrin, within your organization, you're really following the implementation of digital health solutions in South countries. And you can see that we lack hindsight and feedback in terms of data to take the right decisions to develop those digital tools. So just launched very recently a very important study on remote health systems in Mali and in Nepal. Can you tell us what systems we're talking about? Why did you do this study?
In Nepal, we created a telemedicine and tele-expertise network. That is to say that we connect doctors or nurses, health professionals that are in primary health care in rural areas to specialists in hospitals. So it's not a connection between doctor and patient, but it is between doctors and specialist physicians. So it makes it possible for professionals in rural areas to be connected, because traveling around can be complicated. Even if it's only a few kilometers distance, you can take several hours. We've been doing this for several years, for a long time. And in Nepal, we have noticed that the number of women in telemedicine has increased. We have observed that there is a need now to carry out a scientific survey with data that will make it possible for us to make decisions on this. So it is important to analyze the role of telemedicine in rural areas to improve access to healthcare, but also, does telemedicine improve everything? What is your theory? What are your hypotheses that make you conclude that women are more numerous and women use these services more? Perhaps the study will show that there is no difference, but in any case, with the retrospective data that we have, we can see that a lot more women consult. It is a facilitation for women to have access to health services. Women, through telemedicine, can be connected to hospital, and this is a nice, good way for women's access to improve. Indeed, this can be a good way of proving that this service will be good for women. When you launch this study, you said this study is extremely complex because data collection about women is complicated. Well, it's not so much data about women, but generally speaking, when you work in digital health, you know that we still lack a lot of data and evidence, but it is also easy to do. We also have methodologies in place, but it is complicated because in maternal health, for example, for women, sometimes we need to wait for 10 years before we can see results, and then the project has disappeared. And there's a practical side of it as well. Health professionals are overloaded with work. We have to recruit more people to collect data. We had recruited men and women for this, because men didn't want to answer questions when it was a woman asking the question. There's a lot of complications of this nature, and that is a reason why probably we need to do a lot more, where we can see with you the difference between what we can imagine in terms of digital applications and then the field reality. It is interesting. You carried out other studies on other subjects, on diabetes, for example, the risk of diabetes in pregnant women. And already then, you had questioned the distance tools, the telemedicine tools. Well, as I said before, there may be complications, because some women asked us not to send the results, because very often it is a man who has access to the telephone, and the wife, the woman, doesn't want the husband to know the results. It is not the fault of women, but it is a cultural reason, and it is complicated. So when we design solutions, we must take into account all societal aspects. Smisha, Agarwal, we can say that data collection, the collection of good data, good information is absolutely crucial. It is difficult, but you say that if we limit the data to the fact that we are talking to women, we can get it wrong. And you insist on the notion of intersexuality that has to be taken into account. What is this notion of intersexuality?
Intersectionality is the idea, and I think Renu in her opening remarks described it really well when she said that just our gender does not determine how we experience the world. As a US-based professor, the gender dynamics that I experience are very different than who I was. I'm not disempowered, right? But when I was in India as a social worker, it was a very different gender dynamic and environment that I experienced. So it's not just our gender, but a combination of a multiple factors that really determine it. So when we are gathering data, often in the digital space, it remains about women's access to phones. But a upper caste woman in Renu's example versus a different caste woman who are considered lower on the spectrum in the Indian society, their access, their financial capacity, their literacy, everything all of those factors determine how they experience the healthcare sector. And so as we're thinking about data, continuing to gather information about digital literacy, socioeconomic status, educational attainment are all important dimensions which even within the same gender affect people differently. And that's the intersectionality.
Aparna, vous souhaitez compléter?
What is the question?
Yeah,
Would you like to complete what Ms. Smisha has just said?
Yeah, but one more thing I want to talk about data collection from the gender perspective, and this is something I've learned as an ARMMAN founder. You know, when you have child health, we used to look at child health data overall. We didn't stratify based on data. You mentioned it. And I was so ashamed of it, right? Later on, we realized that more girl children suffer from chronic undernutrition than male children. In our programs, we are now tracking that. Unless you track that data, you're not able to go and improve your data, right? So we're tracking how the girl child does with respect to the male child. We look at the nuances or determinants of their lack of access to care. And that has helped us improve our program tremendously. But it didn't start off like that, you know. And it's a learning process for us also. The gender plays such a big role in. And also, like I said, earlier, when talk of gender-based data collection, we would only speak to the woman earlier. When we were doing our evaluation, it was only women we were asking questions on behavioral change. And now we realize that we have to speak to the husbands and the family members to understand the reasons for lack of adoption of behaviors.
Aparna, ma toute dernière question, mais je voudrais qu'on reste un tout petit...
My very last question, Aparna, for you. What about men in all this? What do we become? What is of us? Men, do we have to leave the room? Do we have to become invisible? Or do we still have a role to play?
Role to play because of the fact they are the ones who actually hold the decision-making key. So one thing is, earlier, the way we are transforming our programs is that earlier, they were the ones who were just coming. They were disinterested partners. Maternity or child health was a woman's domain. It is not a male business. But then they would come in when decision-making was required, when there was a crisis, like heroes. But the thing that has to change, and that's what our content is moving towards, is that it's a husband and wife together who are pregnant. Is the child is both of theirs. And also, they have to be engaged in the continuum of care from day one. Right. So, and second thing is that the husbands have to also understand that the wives have to be partners, equal partners, the shared decision making. So the content, the way we have got a kind of device is that by introjection they learn how to involve the wives in that shared decision making process. So it's a husband and wife together who decide for themselves and their children, and then involve the family members as and when required. So then the primacy of the woman and not the mother-in-law, becomes, Yeah, and third thing that we're doing, it's also a patriarchy thing, right? A lot of the women have imbibed those patriarchal gender norms, So the mothers-in-law, the way they behave, and in media always stigmatizes those women, right? If you look at Indian media, the mothers-in-law are stigmatized, right? It's very horrible, right? It's the way they talk about the very bad mother-in-law. But then what we've done in our content is to have an informed mother-in-law who's involved, and who actually helps the husband and wife in their decision-making process in a very positive manner. So women will learn by introjection. And mothers-in-law would like to be like that mother-in-law.
Et si j'ai bien compris,
So if I understand well, this perspective, associating men a little more in this gender transformative process, it is something that you've seen for a few years in your country? It is a novelty?
A novelty, and I'm very happy to say that we run Government of India programs. And just last 2 weeks ago, we got the permission for this content to go through the country. And in a patriarchal country like India, to have Government of India programs speak this language is a very big deal. It's been so heartening. It's at the basis of all, that we need to do in the gender work. Right? There's a long way to go, but it's great that the Government of India has accepted it. Yeah.
merci à toutes les quatre.
Thank you very much to you all. Stay with us. I think they deserve a round of applause. We can see that it is important to go on the ground and to to do the last mile to understand how digital tools can be developed. If you have any comment, any question, please prepare them, send us to them in writing if you are at a distance, or if you're in the room, we'll pass a mic around so that you can ask all your questions to our guests. I suggest we go to the other end of the world, to those who are listening to us from very far away in Laos. Chan. Chan is a coordinator in Laos for the Pierre Fabre Foundation. I hope you can hear us. Chan, can you receive us? What time is it for you? And what's the weather like? Make us dream. What time is it and what is your weather like? We can see you, Chan, but we cannot hear you. I think Chan has gone to get another mic. I don't know whether we'll be able to establish the connection because Chan has disappeared. Well, we'll come back to you in a few minutes when the connection... Hello?
Bon, on vous retrouve d'ici. Okay. On a un petit souci avec votre micro.
We have a sound issue. We'll come back to you in a few minutes to see if you have any questions to ask our guest speakers this morning. Madam, who would like to ask a question from the room? Are there any questions for our guests? Jai.
Aparna, very heartening to know that Government of India has accepted your ARMMAN program. So what it takes for you to actually scale this up pan-India?
So we, from the time of inception of ARMMAN, we realized that it's very important that we work with the government health systems to achieve true scale and cost-effective scale. So the way we have our programs is a co-invested public-private partnership. Government funds the program and the scale-up, and we fund ourselves, because unless we fund ourselves, there won't be any innovation and augmentation. So the way we worked actually is that we started off with our own program called Mitra, which is a voice calling service to women that, through pregnancy and infancy. And we went to 3 million women in 9 states, and the Government of India noticed the success. In 2018, they came to us and asked us to take over their program. It is a similar program called Kilkari, and the idea was to innovate and augment it. And then COVID struck, but I'm very happy to say that the augmentation plan is in place. And now we are going, so the thing is in the digital space, you have to keep pace with the changing norms of technology use of the women and families themselves, right? So, you know, India has become, the spread of smartphone is significant, right? It really allows two-way communication and multimedia approaches. So we've got the permission to go ahead and do that. And now we are going to have increased emphasis on high-risk factors in women and children and equity encumbrance. So if you've got a high-risk factor or equity encumbered, I spoke about the 5 subdivisions like scheduled caste, scheduled tribe, Muslim women, adolescent mothers. And we are hoping to have increased targeted approaches, lateral approaches, two-way communication, hand-holding for that inequity or risk factor. So, and it's with the Government of India. Same thing with the health worker training. So we work with health workers at every level. The ASHA training program in the country, we run the mobile health-based solution. So we've reached around 50 million women and trained over 414,000 health workers in 20 states of India.
Oui, Jai, on vous apporte un micro pour la traduction.
Yeah, it's a connected question. I was expecting this localization because India is like easily 30 plus countries put together.
Yes.
L'Inde, c'est comme une trentaine de pays chez nous. Et donc, il vous faut, et plusieurs langues également, donc il vous faut vous adresser aux patients dans leur langue.
Right? It's not only the language, so even different languages, and in fact, many dialects. So if you look at Madhya Pradesh or in some of the bigger tribal languages, we have it all translated. And also when it goes from one state to the other, it's not just the language, the cultural nuance, the myths might change. So all of the content speaks to all of that. And like I said, for Muslim women, we also have culturally nuanced content that speaks to their cultural influences, etc. So it's very tailored to the ground.
Je prolonge votre question, Jai, jusqu'à Genève.
I asked your question to Geneva, the question of the language, the model of language, the ability to translate from one language to another, but while taking into account the cultural specificity. You take this into account in WHO, don't you?
And I think it's something we need to do more of. But I know particularly there's been some thinking around large language models of which chatbots are that chatbots use, and there's some specificities that may not be easily translatable, and particularly in areas of like reproductive health, you know, talking about body parts, et cetera. And the way you communicate it, there's a lot of cultural nuances that vary beyond even just the direct language translation, which is something that we're trying to understand a little bit better, just understanding that in AI, you know, the machine may not be able to readily understand those nuances, and there needs to be some work to be able to make those linkages. And there's been some great work happening in Kenya with Jacaranda Health and others, where they're really trying to go a little bit deeper into making these translations for languages such as Hausa, Swahili, Zulu, etc., where the direct translations may not be always appropriate, and you need to get to that additional level of contextualization, or what they call transliteration. Thank you.
Quelque part, vous me rassurez dans ce que vous dites, Tigest, ça veut dire que l'humain a encore quelque chose à jouer dans cette histoire-là. D'autres questions, d'autres remarques? Messieurs, on vous apporte des micros.
Could you introduce yourselves when you ask a question, please?
Hear me? I'm speaking in English because my question was to Aparna.
Yeah.
I was definitely, through the discussions, I was thinking about the role of the mother-in-laws and how impactful they could be. At the end of your talk, you mentioned the question of the mother-in-laws, but I was rather thinking about the psychological mechanism behind the behavior of mother-in-law. Are you assessing it? How could you explain, or how they explain themselves, like 20 years before or 30 years before, they were like suffering some of the problem issues we are pointing, and later on, becoming mother-in-law, they are actually acting against women, against wives. This is more or less for me the question. What is the rationale?
You'll be very surprised. I would like you to come to our field, really, I mean, what happens is women are voiceless. The mothers-in-law have really suffered a lot, as you said, and when you get their voice in, you ask them the questions, right? I mean, when we go into evaluation, we really actually talk to them also to understand in our preliminary research, and then even the evaluation later on to see how the program is working, their voice is taken in. And when that happens and they feel heard, there's a transformation. Secondly, it's a power dynamics at play, and that power dynamics is play not just because of they think that way. It is a gendered thing inbuilt in them from years of patriarchy, right? It's that whole patriarchy. You might think that women work against other women. It's not that way. It's just been so imbibed and enforced by society. And when you discuss that, and you have the nuanced content discussing that, if you look at the content, it marries tradition with small modern touches. So if you look at the mother-in-law character, it has got a lot of research has gone into developing the mother-in-law character, who is somebody who is modern yet in touch with her, traditional choices, but also recognizes that she needs to change with time. So hopefully by introjection, those behaviors, Yeah.
La question universelle de la belle.
This is a universal question about the mother-in-law in all the countries of the world. Another two questions in the room. Madam?
Nyasia from Kenya, and thank you to the presenters. My question, I don't know who this will go to. I worry, when we think about digitalization, I worry about adolescent girls and young women. We are already talking about mother-in-laws, they are not married. We are talking about language, and I know, for example, in Kenya and across Africa, we have a language called slang. I don't know if we have such across other countries. This is a language that has been broken down that is both in Swahili and English, and thinking again about the health-seeking behaviors of adolescent girls and young women, and I talk this with a gender lens. They will be looking for this information in the middle of the night. How do we make this information digitally available for them? And also this information, appropriately available for them, and who is this that is providing, which is this digital platform that is available to take care of their needs. Also appreciating that they would not also maybe be in a position to afford even the bundles for them to either access a chatbot or a website or a WhatsApp platform where some of this information could be. Thank you.
Qu'est-ce qui peut répondre, Smisha? Très rapidement, et ensuite on enchaînera sur la suite.
Very briefly, please.
Very complex question, very briefly. So, but I think the access to internet connectivity and digital data, even amongst adolescent girls, is actually rapidly increasing. But you're right, it's not equal in all parts, especially not in rural parts of most countries. In urban parts, there is high accessibility, and there is a rapidly changing, way in which people access information, where in the older generation, people still need to see a face-to-face doctor. The younger generation is much more comfortable with digital services. I think there was a survey conducted of young people that suggested that over 65% of them, and this was in 6 sub-Saharan African countries, that said that 65% of them access mobile health services. And so a lot more research actually is needed to understand how we can make that information accessible to young people. And then, as I've previously mentioned, ways of like chatbot and online services, there's need for privacy, but it's also offering a really good advantage because there is some level of secrecy, which face-to-face services don't often have. And there's reduction of stigma in an online environment, which again, the face-to-face services don't really have. So changing trend.
Merci à tous nos intervenants de cette première table ronde.
Thank you to all the speakers of this first panel. There's still a lot more questions, but we'll answer them later on. I'll let you go back to your seats.